When Meena gave me this topic to speak about ARMD, as usual, I collected all my slides and tried to search the net. And frankly speaking, the more I searched, I developed a severe headache. Primarily because there is so much of information available about ARMD. Then I tried to collect data from various companies. There's a lot of marketing, Lucentis, Macugen. So I actually got confused what to speak. So I'll try to develop an algorithm what Dr. Meena had told based on whatever data I have. We are all born like this, and sometimes, unfortunately, all of us, I think, may develop CSR, this thing, ARMD, and therefore I think it is important for ourselves also to know. Sometimes jokingly I tell Dr. Tiwari in the OT, why not have a prophylactic Lucentis in his eye? ARMD, we all know, is a degenerate disorder and is one of the major cause of irreversible visual loss. And the incidence keeps increasing with age, both of neovascular as well as non-neovascular ARMD. The pathogenesis we don't understand, but treatment, all of us venture into it. We know that it's a dry or wet. Even patients nowadays keep asking lots of, we have dry or wet. And we all understand that wet is the main thing which causes very severe visual loss, apart from the geographic atrophy. Manifestations, I need not tell, but main thing is the colloid bodies, pigment alterations, geographic atrophy in dry, and CNVM and its complications in a wet form of ARMD. This is a slide where I will spend some time. That drusen could be hard. You see small, tiny drusen, you can, it's a non-progressive kind of thing. But if you have large number of soft drusen or sometimes confluent drusen, this is the patient to be watched. So this is very important to see the size of the drusen and the coalescence. Why? Because if you have small hard drusen, it's we call low risk non-neovascular ARMD. If you have excessive medium-sized drusen, we say it's an intermediate kind of risk. And the risk here is 18% progression over 5 years. But if you have soft drusen, 15% risk over 3 years only, this patient is likely to progress. And that is the reason why we want to see soft drusen, hard drusen, coalescent drusen, so that we can talk to the patient that you run approximately 15% chance over 3 years. And it is important, believe me, to talk to the patient in this way, otherwise you lose the compliance. Females, smoking is some of the risk factors which we keep telling. Patient says what I should not do. Smoking, definitely you should avoid, and avoid UV exposure, and control hypertension, and pay attention to this omega-3 fatty acids. So risk factors include more than 5 confluent soft drusen, focal hyperpigmentation, or one large drusen, 63 microns. Arteriole at first bifurcation is around 100 microns, so you can have an idea what is 63 microns. In a patient who has systemic hypertension, if all of them are present, believe me, the risk 5-year incidence of CNV is as high as 85% compared to 7% if none of them are present. So this is important to understand once you are counseling your patients. Symptoms, anything sudden happening means get your retina checked up, and if patient has metamorphopsia, rule out ARMD. Signs are drusen, or patient may have a subretinal bleed. So other dictum is, any patient who has a subretinal heme, don't fool yourself by saying it could be a choroiditis, amoebic choroiditis, or a hemorrhagic choroiditis. CNVM is the first thing to be ruled out in all patients who have subretinal hemorrhage. And after that, once you see the signs, symptoms in a predisposed eye, subject this patient to angiographic studies. And why angiography in this era of OCT? A lot of people may say, I'll directly do OCT. If you have to inject only, why do all these things? The reason we still insist that you do a FA is because you have to topographically localize whether sometimes there is extra foveal CNVM or sometimes juxtafoveal also, which may be more amenable to laser treatment, and the treatment may be prolonged. Treatment result may be permanent kind of stuff. Other thing is to differentiate between classic and occult, because classic we all know responds in a much better way. Therefore, on angiography is important in all patients of CNVM, especially at the first visit. This is how this is subfoveal, this is extrafoveal. Classic CNVM, the bright hyperfluorescence begins very early and then leaks like this. In an occult, the leakage starts much later, and it's irregular stippled kind of hyperfluorescence which stains like this. And sometimes the leakage may be at the level of RPE, that means the leakage does not correspond with the anatomically what you see on the color photograph. And emphasize on digital imaging. I think all of you have digital cameras. The primary advantage with digital imaging is you can have multiple view mode, you can compare vertical follow-ups, and if you plan to do low fluence or standard fluence PDT, you can measure the GLD in such cases. So once you diagnose, our three aims once we talk to the patient is to prevent further visual loss if possible. Whatever patient vision has, can we improve this vision? And don't forget the fellow eye by giving him an Amsler chart. Prophylaxis, a lot of things have been discussed. Even lasers were discussed by this CNVM PD trial. But believe me, threshold or cognitive lasers today have no role. Apart from sometimes satisfying yourself that Drusen number may decrease, the CNVM does not decrease with prophylactic use of laser. The thrust of prophylaxis is on medical treatment. And this landmark study by Eridis 1, where there were these 4 groups and huge, powerful study consisting of a lot of patients. And what this study told us was that development of advanced AMD is significantly reduced if you give combination of both antioxidant and zinc. And the benefit is less if you give zinc alone. So you have to give antioxidants plus zinc. And the conclusion from this study was that if a patient has extensive intermediate drusen or one large drusen which is more than 63 and in non-geographical atrophy in one eye or both eyes or advanced AMD the other eye, should be treated with antioxidant zinc. The question which patient asks is, for how long should I keep taking this? Because this duration was not clarified. But there are some concerns also. Implications of Eridis is about the side effects sometimes or this because the dosage is very, very high. So Eridis 2 has started in 2008, where they are evaluating this role of xanthophylls, that is lutein zeaxanthin, plus PUFA, that is polyunsaturated fatty acids, omega-3 fatty acids, DHA and EPA. An additional goal of this study is to try and reduce the zinc with no beta carotene. The results will be out in 2013. But these are the criteria which I think is not. But what we tell all patients of dry AMD is no smoking, BP control, diet rich, and if they are non-veg, try to eat fish. There is a study which shows that fish eating, I told West Bengal people also, do one study in West Bengal, do somewhere non-fish eating population. There is a difference in the incidence of ARMD. What about treatment? We all forget, giving these patients low vision aids. There have been studies which say MIT kind of lens, that is miniature implanted telescopes, which provides magnification to these patients, does help. And also low vision aids should not be forgotten, because these elderly patients just want to sign checks and, read those, whether it is 5,000 or 5 lakhs of rupees. Amsler grid monocularly has to be done, monocularly. Coming to the most important part, I think, which which draws maximum attention is what to offer, ranging from all this confusing kind of treatment which is available. And there has been, believe me, in our era itself, we have seen, when we were residents or early part of consultancy, we used to just give B complex in subfoveal CNVM and prognosis explained. But it has undergone a sea change from the time of MPS reports. Then came this cold laser. This was a destructive laser, then cold laser, then submacular surgery also came and went away, and after that came this miraculous drugs or marvelous drugs, anti-VEGF, and huge number of studies are available. Thermal lasers, the quality lasers are indicated in very few percentage of patients. But whensoever we do it, I think we are relieved and patients relieved, something like this. Far away, miles away from the macula, effect post-laser generally is permanent. There's another patient who had angioid streaks actually and had this CNVM, had the courage to do laser, patient still maintains very good vision after 7 years of follow-up. Subfoveal CNV is the problem we have to face, because if you do laser, as MPS study had said, there is an immediate precipitous and patient keeps cursing you the whole life. Then came the era of PDT and TTT. TTT came with a bang, and I heard a lot of presentations in AIUS, but it went with a bang also, frankly speaking, and came PDT, which is cold laser. The aim is to, destruction of subfoveal CNV with no collateral damage. I'll take 2 minutes precisely more. Various studies, TAP and VIP trial, but these are the graphs. PDT. So PDT delayed the visual loss. The graph still keeps going down rather than going up. This is at baseline. This is the placebo treatment. This was the era of PDT, personal series, where you see the FA at that time we were using. Result is pretty okay. Then came this era of VEGF inhibitors, and Macugen was the first VEGF inhibitor to get FDA approval. Then Lucentis, Avastin still not approved, but still recently CAT studies have come where they have shown non-inferiority with Lucentis. Newer VEGFs are coming. This was the results of vision trial, and the same thing you see similar to PDT, that this delays the visual loss. Then came this wonder drug Lucentis, Mirena, Anchor, lot of studies. They showed for the first time that the graph now starts going up instead of going down. So they are the in thing, the fashion of the day. Everybody wants to inject. So many studies are available. So many of them that I had to borrow this graph from Lucentis people and show, just to tell you that it does work. And this posology has been approved by European Union that Lucentis is initiated with a loading dose of 3 injections and then into a maintenance phase. This is our one patient, you see first injection, he improved, second injection, third injection, fourth injection. But every month precisely he will come and complains of metamorphosia. So for how long can you give Vantage? So can Lucentis eradicate CNVM? It can, but very, very rarely. It depends on the maturity of the vessels we are dealing with. So there are issues like Lucentis cannot close the tubes. Even medical issues like the more you keep giving, the more the risk of endophthalmitis per injection, and the risk increases over 2 years. The cost is another factor to be considered. So what do? You increase the duration, treat and extend, keep increasing 2 weeks until the patient is stable, or do a guided study by OCT. The idea of a combination came from the focus trial actually. I'll just take 1 minute, Meena. So we did this study a couple of years back of combination treatment where we used low fluence PDT along with Avastin and Lucentis, the 37 eyes, and this was the result that there was complete resolution documented on angiography in 75% of patients, whereas partial resolution in 25%. So what we hypothesized was complete resolution within 3 months occurs. Can you stop this noise here? Within 3 months in 100% of the patients who are receiving Lucentis. Just try to conclude. This is one of the patients from that study. He had a bilateral classic CNVM which responded to this combination treatment, and after that he didn't require another injection. These are the OCTs of that patient showing pre and post. Lot of our ARMD patients have in this part of the subcontinent IPCV, polypoidal choroidopathy, and in this disease Lucentis or Avastin is not the first line of treatment. It has to be PDT plus minus anti-VEGF. This is one patient which we had multiple RPDs, conical RPD, massive subretinal hemorrhage, serious sanguineous response, polyps here. So this we treated gas we had to inject because there was a large subretinal hemorrhage, and then we did PDT and anti-VEGF in the same sitting, all three in the same day. And this is the final result after combination treatment. This treatment does respond, this disease does respond to PDT and combination. Another patient, just to exemplify that PDT and anti-VEGF do work. Recently, these CAT studies have come that we say CAT is out of the bag. And what they have shown is monthly Avastin is non-inferior to monthly ranibizumab. Although the study was not powered enough to evaluate safety, but it raised our hopes and made us feel confident that you can give Avastin in these patients. Last is VEGF trap, which has recently been approved in last year only, approved by 10:0 vote on FDA panel. This also had a tough time, but the advantage of VEGF trap is that after the initial 3 monthly dosage, in a dose of 2 milligram every 2 months, this works and is a new treatment option. It is available by the name of Eylea in USA, and in India, Bayer company most likely will be marketing. This had to also undergo phase 1 study, Clear IT study, Clear IT 2 study, then View 1 study in USA and View 2 study outside USA. This have demonstrated 2 identical non-inferiority phase 3 studies. So where are we? What is the best approach? What is the take-home message now? The rational approach after all this confusion is based on personal results as well as randomized results. What we follow is, if we have a predominant classic CNVM with reasonably good visual acuity, VEGF inhibitors, loading dose, 3 doses, 3 injections, and then if after that 3 injections, monthly monitoring is very important. Every month you have to see. And if patient still has non-response, recurrence or tachyphylaxis, then we do not hesitate to add low fluence PDT in patient of classic CNVM. However, if patient is visual acuity poor, I think the same thing we follow in all these patients of classic CNVM. That is initial loading dose of 3 injections, follow up monthly. If recurrence, non-response or tachyphylaxis, add PDT. It will take away a lot of your headache of repeated injections. However, if you have occult CNVM with very good visual acuity, then we do not do PDT at all in such patients and maintain these patients on monotherapy, because occult is very, very unpredictable and the response is not as great as in classic CNVM. There are occult patients of CNVM where there is a minimal visual loss, minimal symptoms. These patients should not be treated at all and should be only on close observations. So, in the end, I'd like to conclude by saying, although there are a lot of options available, the best results to date, unparalleled, is with monthly injections. But short of that, I think after the loading dose, you can have this flexible approach based on monitoring by vision and OCT. So best outcome is with monthly injections. Flexible can sustain vision nearly as close possible to Marina and Anchor. But what is important is MM. MM means monthly monitoring for identifying all active disease. Active disease means these one of them have to be there. That is, vision is decreased by 1 line, any new cerebral hemorrhage, an FA new leakage, or increase of OCT. So if any one of them is present for 1 month, please re-inject. So believe me, we have yet to have the last laugh. Best is still to arrive. People are giving super dose Lucentis also. There are a lot of further studies going on. But as of today, whatever I described, that is the best protocol to follow. Thank you very much.